I have the pleasure of introducing Dr. Matthias Maiwald. Dr. Maiwald is a senior consultant and the head of service microbiology at KK Women's and Children's Hospital and an adjunct associate professor at the Department of Microbiology and Immunology, National University of Singapore, and at Duke National University of Singapore Graduate Medical School in Singapore. Dr. Maiwald, the floor is yours.
Thank you so much, Kevin. Thank you so much for the invitation. I will talk about irregular and out-of-season re-emergence of respiratory pathogens after lifting of COVID-19 pandemic measures in Singapore. I have no disclosures to make, so I'll jump over to the next slide. The background is that Singapore was hit quite badly by the 2003 SARS outbreak, the original SARS, and Singapore took a painful lesson. And the lesson was that due to its exposed location as trade and travel hub, Singapore is extremely vulnerable to imported infections. And in the intervening years between 2003 SARS and 2019 COVID, Singapore spent quite a bit of effort to prepare for potential next pandemics. And that explains some of the response measures that Singapore has taken and was able to take. So a bit of an overview. Singapore is a tropical city-state with about 5.5 million population. And the COVID situation at a glance is here. And the official daily reports were discontinued on 13th of February 2023. So we have the data up until then. The total cases were a little bit over 2 million. And the total deaths were 1,722 people, which accounts for a death rate of 0.08%, which is a remarkably low death rate in international comparison. Vaccination rate in Singapore is generally good. Over 81% of the population have a minimum protection. So if we look at the pandemic response measures that Singapore has taken, it's on this table here. In 2020, when the COVID pandemic struck us, in February, there was a phase called DORS-CON Orange, which is a disease outbreak response code, something like a pandemic alert, and it was raised to orange. First restrictions came in, including travel restrictions. Then in April 2020 came a complete lockdown, hard lockdown, the so-called circuit breaker. And from June 2020 onwards, there was a phased reopening, still with the safe distancing measures remaining in place. Masks outside the home remained compulsory. And from January 2021, the loosening of measures continued, but still mask wearing and safe distancing measures remained in place. Then May 2021, there was a heightened alert phase. The tightening of measures was done after COVID clusters of the Delta strain emerged. A routine roster testing RRT of all healthcare staff was done. And then subsequently, again, a slight loosening of measures. September, October 2021, there was a so-called stabilization phase. This was accompanied by a rise in COVID cases and deaths of the Delta strain. Again, measures were tightened. In 2022, there was a transition phase, further transition and further easing of measures. And in April 2022, the outbreak alert was lowered from orange to yellow, which was accompanied with further relaxation of measures. So there was no more requirement for trace together and safe entry. Those are digital tracing measures that the Singapore government implemented, and fully vaccinated and clinically well travelers could enter Singapore. Then October 2022, there was a so-called transition phase to resilience. Mandatory mask wearing was only needed for healthcare facilities and public transport. and fully vaccinated travelers could enter Singapore without testing or quarantine. Public life returned to near normal, and then in February 2023, the outbreak response code was lowered to green again. Mask wearing was only mandatory in healthcare facilities with patient contacts, and all other restrictions were lifted. So this is the outline of the Singapore pandemic response measures, upon which the remainder of the presentation is based. So what we observed is a disappearance and reappearance of respiratory viruses during the COVID-19 response measures. What we are doing in our laboratory, and we are serving a large women's and children's hospital, so the microbiology testing that we do is slanted towards women's and children's diseases, and for children, obviously, respiratory infections play a relatively large role. So around December 2019 and January 2020, there was a large proportion of positive cases, and that was mainly influenza A and B. Then when COVID restrictions set in, like the DORSCON orange in February and the hard lockdown in April, and the reopening phase 1 in June 20, and the phase 2 later, and the phase 3 then again later in 2021, what we observed was that around April 2020, we noticed that less than 1 in 10, just roughly, of respiratory pathogen PCRs had any pathogens. And I was sitting at the bench reporting our microbiology results and was wondering what is going on, have all disappeared? And then about 13 weeks after the start of the reopening, enterovirus, rhinovirus reappeared, and later adenovirus. Just take a note that in the assay that we are using, enterovirus is not distinguished from rhinovirus. That's why I usually have EV/RV. And into 2021, other viruses reappeared. Then in 2022 and 2023, more viruses and some bacteria reappeared, but the patterns were unusual and out of season, and some of the peaks were actually higher than before the pandemic. And in total, we have a data set now between 2019 and 2023 of over 80,000 tested specimens from patients. So this is the assay that we're using. It's the BioFire Film Array RP2.1 multiplex PCR. It is a rapid multiplex PCR with 19 respiratory pathogens and COVID. The earlier incarnations of the test didn't have COVID, but they were subsequently improved. And these are some of our data here in this slide, which were published in JAMA Network Open. So what you see is on the left half of the slide is the year 2019 with its usual pre-pandemic seasonal variations. And on the right side of the slide is year 2020. The grayish bars display the total number of samples tested per week. And the lines here in different colors represent the different viruses in this case. This slide doesn't include bacteria yet. And so what you see is the red line is influenza A and B. Usually Singapore participates in Southern Hemisphere and Northern Hemisphere flu seasons because Singapore is located in the tropics and it gets travelers from both hemispheres. Then if you look a little bit further, if you look at the black line is RSV, respiratory syncytial virus. It usually has about a mid-year peak around June, July in Singapore. Then the bluish line, enterovirus, rhinovirus, is hovering up and down and present most of the year. And then we get some of the other viruses hovering around, adenovirus in green, parainfluenza, etc. And then when you look on the right side of the slide, you see that in the pandemic alert level, orange, influenza, the red line, goes down very rapidly, potentially travel associated because there were travel restrictions in place at that time. Then came the lockdown, and after the lockdown, you can see that most of the other viruses went down to very low levels. You see here where on the bottom of the slide it says flu season, we have a near gap, a near absence of all respiratory viruses here. Then into the reopening, we see some viruses reappearing, and enterovirus, rhinovirus reappears first, subsequently followed by the green adenovirus on this slide. And what we are assuming or speculating is that because enterovirus, rhinovirus, as well as adenovirus are so-called non-enveloped viruses, and these viruses are much more resistant to environmental conditions, we assume that despite the presence of mask wearing, there could be a portion of contact transmission that may have been going on in that phase, so that the non-enveloped viruses were spread. So this slide here shows you another depiction of basically the same data set. The background of the slide has the different pandemic levels, lockdown, etc., etc. And the blue shades are the pre-pandemic occurrences of the viruses. So you can see that the viruses here have different scales. So just don't get confused by the different scales of the slides. So for example, on the bottom, metapneumovirus, the bars look high, but the scale is much less. So if you look at the top left, influenza AB had a very big peak between December 2019 and January 2020, but then that went down to nearly zero. Enterovirus, rhinovirus, which is on the right top side of the slide, nearly disappeared, but only in complete lockdown, and then re-emerged as the first types of viruses. Adenovirus re-emerged a little bit later. And on the bottom right, you see the so-called Oxford Stringency Index, which means that it depicts stringency of the measures applied in Singapore. So this is the next slide. Similar trends were seen in other countries. So where some of the usual influenza seasons were basically absent in 2020. And then, of course, this slide asks the question, what happens thereafter? What happens when the restrictions are lifted? And on the left side of the slide, you can see that Australia was experiencing off-season RSV epidemics after the easing of COVID-19 restrictions. Similar, southern Italy, and similarly, Japan. And from my native Germany, I know from the news that at that time in 2021 and in 2022, the children's hospitals tended to be overwhelmed with children coming down with RSV. Some other viruses resurged. For example, here on the left side of the slide, you see an unusual resurgence of human metapneumovirus in Western Australia. Here on the right side, you see again a slide about influenza, where in the southern hemisphere in Australia, the peak came earlier than the usual southern hemisphere peaks. And on the bottom of the slide, you see again what I mentioned earlier, that Germany was quite hit badly with RSV outbreaks. So in Singapore, we experienced in 2022 that influenza A/B cases started rising mid-2022. RSV surged early and mid-2021 and 2022. And then in late 2022 and 2023, hand, foot, and mouth disease, which is caused by enterovirus, which was absent up to then, reappeared in Singapore, and we also saw again a few enterovirus meningitis cases in children. And here, this slide shows you some of the percentages of respiratory viruses between 2019 and 2020. So what you're looking at here is on the left, the scale is the percent of submitted samples. So this is no longer the absolute number, but the percentage. And again, in 2019, you see that influenza has about 2 peaks in December and January, and in mid-year, RSV usually has a mid-year peak, and adenovirus usually has no pronounced peaks, and enterovirus, rhinovirus hovers around all year. And we saw an unusual influenza A peak at the end of 2019, lasting into the beginning of 2020. And then on the bottom of the slide, you see when the pandemic alert level was changed to orange and travel restrictions came in, influenza went down, and then other viruses disappeared when there was a hard lockdown. And then upon reopening, as I mentioned earlier, enterovirus, rhinovirus appeared first, and then adenovirus reappeared. So this goes into 2021. What you see here on top of the slide is in 2021, in the green line, you see a pre-seasonal RSV peak. It came much earlier than the usual RSV and also in higher numbers than pre-pandemic. And again, Singapore, as mentioned before, had a few phases where restrictions were tightened. So, for example, in May 2022, tightening of restrictions, and there was a tendency for viruses to go down. And again, in the second half of 2021, there was a Delta wave of COVID where heightened restrictions were applied again, and viruses tended to go down again. So enterovirus, rhinovirus, as we see, hovers up and down and hangs around. Then if we go to 2022, there is an RSV peak, and that RSV peak is a little bit later. It is in season now, but it is higher than what we used to see. And at that time, if you look at the scale on the left, the number of positives are about 50% of all submitted samples. So that's quite a substantial amount of virus. Then if you look into the second half of 2022, you see that influenza A, red line, starts reappearing, presumably from the southern hemisphere. And in late 2022, we have an unusual metapneumovirus peak, which then subsided and was not seen again. So if we look into 2023, and in February, all restrictions were lifted, or nearly all restrictions, we had a big adenovirus surge. RSV was up in the first half of 2023, and again, enterovirus, rhinovirus hovers around. Influenza A was seen quite regularly again. So in summary, respiratory viruses follow COVID-related restrictions, but not all in the same way. They differ between each other. Enterovirus, rhinovirus, and adenovirus returned first. They are both non-enveloped viruses. And that was when social contacts were increasing, but mask wearing was still mandatory. And this suggests a partial role of contact transmission in the population. There were subsequent heightened restrictions, upon which the viruses went down again. Some countries had RSV peaks that strained children's hospitals, and several viruses had unusual phases of high activity, and their peaks were higher than in pre-pandemic times. And influenza returned only in the second half of 2022, probably from the southern hemisphere. Then we look at the bacteria. Here's a Medscape commentary that in 2023, that is in the US, Bordetella parapertussis re-emerges as a cause of respiratory illness in children. And when we look at the Singapore data here, we see the bacteria here on this slide. First of all, it contains Bordetella pertussis, parapertussis, Mycoplasma pneumoniae, and Chlamydophila pneumoniae. And Chlamydophila, we see hardly any cases. It's fairly rare in Singapore. But pre-pandemic, we saw a constant trickle of pertussis cases. We saw a substantial amount of Mycoplasma coming around. Please note the different scale of the slides, still percentages among our samples tested. And if you look into 2020, after an initial Mycoplasma pneumoniae peak, nearly all respiratory bacteria completely disappeared and stayed away for a long time. And this continued on this slide into 2021 and 2022. So I'm not showing any data for 2021 and 2022, which is a near absence of all respiratory bacteria. But what happens then? Mycoplasma pneumoniae remained near absent until about April 2023, same in many countries. Late 2023 saw a big Mycoplasma pneumoniae resurgence, also huge case numbers coming in from China. Bordetella pertussis remains near absent in Singapore. We in our hospital only had 5 cases since 2020, which is substantial lack of pertussis going around here in Singapore. But Bordetella parapertussis returned around March 2023. It hovers around. There wasn't an outbreak or anything with Bordetella parapertussis, but the numbers are still greater than pre-pandemic. So pre-pandemic, we had maybe about 10, 20 cases a year. Now we are seeing about 100 cases in 2023. So that's quite a substantial increase of Bordetella parapertussis. And Chlamydophila pneumoniae had very few cases pre and post-pandemic. So other parts of the world had similar trends for these bacterial illnesses. And on the right of the slide, you see a graph or a publication that we conducted together with some European authors who doing a global survey of Mycoplasma pneumoniae occurrence. You see in Singapore is the orange line. Some of the other countries have other colored lines. And again, here on the right, in 2020, the bacteria go nearly absent. So then what are the further developments? And what you see here is 2 further papers by the same group in which we are included. Initially, up to March 2022, it was still nearly absent. And then in 2023, which is on the bottom right side of the slide, you see a small increase again of Mycoplasma pneumoniae. Then the further developments are that on the left side of the slide, you see Mycoplasma pneumoniae had delayed re-emergence in 2023 after COVID-19 restrictions. On the left side of the slide, Singapore is the purple line or pink line. I'm not sure what the color is. And then on the right side of the slide, you see an interesting development that came very late in 2023, worldwide, but particularly pronounced in China. We're seeing pneumonia outbreaks due to the re-emergence of Mycoplasma pneumoniae. On the bottom right side of the slide is a paper from China that describes it. And the strains are macrolide-resistant epidemic clones. The interesting fact about mainland China at that phase was that greater than 50% of all respiratory tests are positive for Mycoplasma pneumoniae, which is mind-boggling from my experience as a microbiologist. There are few epidemic clones and a high percentage of macrolide resistance. So the situation in China was the subject of news. And there's an article in Nature that speculates about China's mysterious wave of childhood pneumonias. And there are some other papers coming from China where this outbreak is discussed about. So to summarize our observed phenomena, the COVID-19 pandemic restrictions, travel bans, etc., were associated with a broad decline of many respiratory pathogens. The loosening or lifting of restrictions was associated with pathogen return, but the effects of control measures and relaxation varied between pathogens and phases. Not all pathogens returned at once. Non-enveloped viruses returned first. RSV had early out-of-season peaks and straining children's hospitals. Influenza A returned late, and several viruses had peaks that returned to greater than pre-pandemic levels, so the frequency was much higher. Pertussis remains absent, at least here in Singapore. Parapertussis has a greater than pre-pandemic surge, although we can't call it an outbreak. And Mycoplasma pneumoniae returned after a long hiatus and caused a big surge in China. So what is the situation here? What are we looking here? And here are some papers and or speculation about a so-called immunity debt, which may have arisen. So the immunity debt hypothesis says that due to the absence of pathogens in the initial phase, the return of the pathogens is stronger because people are lacking immunity. So what is the concept of immunity debt? It is that children who were born or raised from young were not exposed to many pathogens during COVID-19 pandemic restrictions. And there are many different respiratory viruses and bacteria. For example, rhinovirus has greater than 100 types. This is similar for gastrointestinal pathogens. And children are now non-immune to many pathogens. And children who were not much exposed during restrictions are now exposed to the returning pathogens. So the consequence of this is more frequent infections and infections at an older than usual age. So children's hospitals before the pandemic saw RSV infections, severe RSV infections, mostly below 1 year, if I'm not wrong. And then in the return of RSV, children up to about 5 years were seen infected with RSV. And there's a possible relationship of this to the hygiene hypothesis, which says that exposure to dirt and less harmful pathogens helps train the immune system, and it may also have a preventative function against allergies. And this is depicted here in this slide, which has a nice title, in my opinion, Why Old MacDonald Has a Farm but No Allergies, Genes, Environments, and the Hygiene Hypothesis. And what you see here is a baby exposed in a cow stable to, all the dirt and things that are floating around there. But there are competing hypotheses. So hypothesis 1 surrounding this is a simple lack of exposure. So people who are not exposed to specific pathogens lack specific immunity. And the classical example around this is the 1846 Faroe Islands measles outbreak. Measles had not been seen for over 60 years on those islands, and no one less than 60 years old had immunity. So over a 5-month period, 6,100 of 7,900 inhabitants fell ill. 100 died, which is a substantial death rate. And the people over 60 years did not fall ill or had much less severe disease. The hypothesis 2, as I said before, is a lack of the training of immune systems. See the hygiene hypothesis. It is biologically plausible, but a concrete support for that in the context of pathogen return is missing. Hypothesis 3 is that COVID-19 itself induces an immune dysregulation, So some other viruses are known to cause mostly a temporary immune deficiency. For example, measles is well known to do that. And some countries that had very little measures had big RSV surges, and some measured immune parameters are different after COVID. So here, this slide shows you an example of papers discussing long COVID and immune dysregulation. And there are certainly immune dysregulation parameters that can be measured in a laboratory setting in patients who had had COVID. So here is some further information on COVID-19 related immune dysregulation. So I'm not an expert in the immunology depicted in this slide, but these papers claim that COVID can have a long-term effect on our immune system, which leads to post-acute sequelae of COVID-19. So, for example, this paper shows that severe infections can cause an IL-6 interleukin-6 induction and a disturbance of immune responses, which may be associated with some COVID-related sequelae and or perhaps long COVID. So in conclusion of this, many pathogens disappeared during the pandemic restrictions and are now reappearing. And I should stress that pathogen absence is an unusual state, not their presence. COVID-19 created a human experiment that was unprecedented in history, and the pathogen return is part of return to normality. And the reappearance is not homogeneous. We see irregular and out-of-season return after a pandemic bottleneck. We also seem to see more serious presentations, for example, in young children and older than usual age at presentation. And to me, which of the hypotheses exactly applies is unclear. In my opinion, it is likely a combination of factors, meaning a multifactorial and very complex phenomenon. And the situation is quite complicated. And in my opinion, there is a need for ongoing research. At this point, I like to acknowledge my co-workers, the team of the Molecular Microbiology Laboratory, Dr. Lu from Molecular Microbiology, Mr. Han-Yang Sung from Molecular Microbiology, and Dr. Wan from the Virology section of the Singapore General Hospital. And I will present these results in a very short time at a conference of the Royal College of Pathologists of Australasia in Adelaide, Australia. Thank you so much for your attention.
Well, thank you very much, Dr. Maiwald. A very, very interesting presentation, I think thought-provoking. Now, my recollection was that there was a strain of influenza that kind of disappeared. Can you elaborate on that?
Yes, from what I know, one of the influenza B strains, but I can't quite recall its name, apparently has disappeared. Yes, I heard that too. And that's very interesting. It didn't return post-pandemic. There are two major influenza B lineages. One of them reappeared, the other stayed absent.
Thank you. Any questions for Dr. Maiwald?